So now you have a patient with a peripheral neuropathy and you find a monoclonal protein on testing. So how do you know? In patients older than 50 years, about 5 to 10% have peripheral neuropathy, and also about 5 to 10% have a monoclonal protein. So just by coincidence, the most common scenario is that you'll have a patient where the monoclonal protein and the peripheral neuropathy is just coincidental rather than one causing the other. So how can you tell that? A rule of thumb that will almost never fail you, and a question that I ask myself every time I see such patients, is the following. How different is the patient's clinical presentation or laboratory finding from an idiopathic peripheral neuropathy? If it sounds like an idiopathic neuropathy, looks like an idiopathic neuropathy, on EMG has no red flags, then it's most likely just an idiopathic neuropathy or neuropathy of alternative cause, and the monoclonal protein is coincidental. So to our audience who do general neurology, what does an idiopathic peripheral neuropathy look like? Which is the most common type of neuropathy. It's always length dependent, sensory predominant, and it's axonal on EMG. What do we mean by that? So patients mostly present with sensory symptoms, usually at onset more small fiber modalities such as tingling and loss of pinprick sensation. And later on, they develop large fiber modalities such as loss of proprioception and imbalance. Motor symptoms are not common. At advanced stages, you can have some toe weakness, but you should not have ankle weakness in an idiopathic neuropathy, or at least you should be careful if you have that. And it's very, very slowly progressive over the years. The lack of any of these characteristics should be considered as a red flag that requires further investigation. And that same rule applies to the paraproteinemic neuropathy. So let's start with an example from the